Thank you very much, Dr. Klein. So today I'll be presenting some preliminary results in an epidemiological study entitled "The Association Between HCV RNA Status and Mortality in a Cohort of HCV and HIV Co-infected Canadians." So I have no conflicts of interest to declare. So just to provide a little bit of a background, in HCV mono-infected populations, there's a clear association between HCV RNA status, so if they're chronically infected versus if they've cleared infection, and mortality. But in co-infected populations, however, the association is a little more difficult to ascertain. And the reason for this is that there are a couple of sources of uncertainty in the epidemiological literature, and one of these sources is competing risks. So in co-infected populations, we're more, as Dr. Klein showed this morning, we're more likely to see other causes of death in addition to end-stage liver disease. So we'll also see suicides, overdose, cancer, AIDS, and even bacterial infections. And what this does is that if we're interested in looking at the effect of HCV RNA status and, let's say, non-liver disease-related mortality, we have to take into account that some study participants might die from end-stage liver disease before we can observe other causes of death. So this has not been accounted for very much in the literature, and so this is something I'm going to apply in my research. And in addition, other epidemiological studies that looked at the association between HCV RNA status and mortality in co-infected populations have not really defined their exposure that well. Most of them, what they did was they defined their exposure of HCV RNA status just once at baseline, and then assumed that over time the study participants would remain HCV RNA either positive or negative. But we know that it's possible that some people who might have cleared the infection could be exposed to HCV, another strain of hepatitis C again, because let's say they're continuing to be injection drug users, so they might be reinfected and might be HCV RNA positive. And alternatively, those who are HCV RNA positive can also become HCV RNA negative if they're treated with and develop the same virological response with ribavirin or pegylated interferon. So the objective of my research project was to determine the association between HCV RNA status and mortality, as well as non-liver disease-related mortality, accounting for competing risks and reinfection. So just very briefly, my studies, the study population that we used was the Canadian co-infection cohort, and this morning Dr. Klein explained it really quite well, so I'll just very briefly, I'll just mention that it's a multi-center prospective cohort study, and in the last 10 years they've recruited over 1,200 study participants. And typically what happens is once a study participant provides informed consent, they fill out a questionnaire giving out information about drug use, other comorbidities, and they also have their bloods tested for HCV RNA, CD4 cell count, viral load, and other measures. And follow-up visits take place every 6 months to update this information. So for our methodology, for our inclusion criteria, we included all study participants who had a known HCV RNA status and more than 2 study visits. And we defined our exposure, their HCV RNA status, by a qualitative HCV RNA serum analysis. So all those that were HCV RNA positive, we considered them to be chronically infected. And all those who were HCV RNA negative, we considered them to have a cleared infection. So this exposure was time updated, so whenever new information came about the HCV RNA status, we included this in the model. And for HCV RNA was not always checked at each study visit, so any intermediate visits where there were no variables, we carried the last known result downwards. So for our outcomes, we looked at 2 specific outcomes. We looked at all-cause mortality, so that's any mortality from AIDS, cancer, cardiovascular disease, infection, overdose, violent death, unknown causes of death, and end-stage liver disease. And we also, for our secondary outcome, we looked at non-liver disease related causes of death. So these were all causes of death except those from end-stage liver disease. And our causes of death were classified according to the classification of death in HIV methodology. It's a way for large HIV cohort studies to make sure that they all have a standardized cause of death classification. And in addition to our exposure and outcome, we also obtained information for additional covariates, so demographic variables such as age, sex, aboriginal status, and if they were current injection drug users. And we also obtained information on HCV-related variables such as time since infection, prior treatment, fibrosis level, which we defined as APRI score greater than 1.5, and their genotype. And we also determined information from HIV-related variables such as their estimated time since infection, whether or not they were on ART, their CD4 cell count, and HIV viral load. So for our statistical analysis, we used the time to event model. So we looked at, we started follow-up on all subjects from their first date of their HCV RNA status up until loss to follow-up, death, or the last date of the cohort study, whichever came first. And so to examine the association between HCV RNA status and all-cause mortality, we fitted Cox proportional hazards models. So this is typically done for time to event analysis. So we looked at the association between HCV RNA and all-cause mortality with this method, and we also included, we adjusted for time the possible effect of confounders using time-updated covariates for HCV RNA status, for age, CD4 cell count, recent injection drug use, APRI, and prior HCV treatment. And we also adjusted for time-fixed covariates such as gender, aboriginal status, and HCV genotype. And to examine the association between HCV RNA status and non-liver disease-related mortality, we fit an analogous model to the Cox proportional hazard model that takes into account competing risks, the fine and gray method, and we adjusted for the same covariates. So just to provide a brief calculation of how many people were included in our cohort study. So we started with 1,238 study participants, and we excluded 52 of them who did not have any HCV RNA status. And we also excluded 137 participants who only had a baseline visit. So this left 1,049 study participants in total, and this yielded about almost 4,000 person years of follow-up. So this totals out to about 3.8 years of follow-up per study participants, which is slightly higher than what Dr. Klein cited this morning because we excluded all those who had just a single baseline visit. So this figure shows the most common causes of death. Again, it was also similar to what Dr. Klein showed this morning, but the data is more updated, so we have more causes of death, and I put them in order of the largest to the smallest, so it's easier to look at. So there were a total of 146 deaths within our cohort. 97 of them had a known cause of death, and the most common ones were end-stage liver disease, overdose, but we also had a substantial number of deaths from cancer and bacterial infections. So overall, if we calculate the overall incidence rate for the overall mortality rate, we have 359 deaths per 10,000 person years. And by HCV RNA status, those who were HCV RNA positive had a higher mortality, 391 deaths per 10,000 person years of follow-up. And those who were HCV RNA negative is still high, but less, was 288 years per 10,000 person years of follow-up. So this figure shows the cause-specific risk of mortality by HCV RNA status. So the red bars are those study participants who are HCV RNA positive, and those blue bars are for those who are HCV RNA negative. And not surprisingly, being HCV RNA positive, you have about a 5-time greater risk of death from end-stage liver disease. But it's also interesting to note that even for the other causes of death, being HCV RNA positive, you're more likely to die from, let's say, overdose, cancer, and bacterial infection than you are if you're HCV RNA negative. So just crudely, it appears that being HCV RNA positive is a risk factor for mortality from deaths from other causes of death other than end-stage liver disease. So before I present the results from the regression model, I thought I would just show the baseline characteristics between those who are HCV RNA positive and those who are HCV RNA negative. It's an observational epidemiological study, so it's possible that there are some baseline covariates between the exposed that are different between the exposed and unexposed, and this may also predict mortality. So these are potential confounders. For those at baseline who are HCV RNA positive, they were more likely to be male. There was no difference really between age between those who are RNA positive and those who are RNA negative. Those who are RNA negative were more likely to be Aboriginal than. No wait, those who are HCV RNA negative they were more likely to be Aboriginal. And there were also some differences between in some hepatitis C variables. So those who are RNA positive naturally are more likely to be treatment naive, more likely to have fibrosis, and also have a different distribution of genotypes. And there were no differences between the exposed and unexposed in terms of HIV-related covariates. So this last table shows the results from our regression model. So the first model is looking at the outcome of all-cause mortality. So that's the column in the middle. And on the right, we have the column for the competing risks of non-liver disease-related mortality. And the covariates are on the left. And this is the adjusted model. So all the results are presented adjusted for each of the other additional covariates. And so for all-cause mortality, we see that those who are HCV RNA positive, as you would expect, have a greater risk of mortality, almost 50%. Also, not surprising, age is predictive of mortality. So for every additional 5 years of life increases the risk of all-cause mortality by 36%. Also, CD4 is preventative against mortality. So for each 100 cells per microliter increase reduces the risk of mortality by 14%. And finally, APRI was also predictive of mortality. So those who have evidence non-invasive liver not for the non-invasive marker of liver fibrosis have a greater risk of death. However, for non-liver disease related mortality, the results were a little bit different. There was no significant association between HCV RNA status and all-cause mortality, though there was a 20% increase, but it was not statistically significant. And only age was predictive of all-cause mortality. So we don't see CD4 count protecting against all-cause mortality or liver fibrosis as well. So just some discussion points. We see that end-stage liver disease still remains the most frequent cause of death in HCV, HIV co-infected populations, but additionally, overdose, cancer, and bacterial infections are also frequent. And mortality in the cohort remains high, so it's 350 per 10,000 person years. It's comparable to other cohorts, such as the EuroCETA or the Danish HIV cohort study for the sub-cohort that's also co-infected with HCV also report rates of mortality that are over 300 or over 250 per 10,000 person years of follow-up. And as Dr. Klein showed this morning, that the rates of mortality in co-infected populations are 10, 12 to 15 times higher than they are in age, sex, standardized general population. It appears that patients with active viral replication appear to have a higher risk of death from most causes. However, after adjustment, HCV RNA does not appear to significantly increase the risk of non-liver disease mortality. But however, I just want to note that we were slightly underpowered to be able to detect an effect for non-liver disease related outcomes. I noted that about a third of our causes of death we were not able to classify, but we're hoping in the next couple of months we'll be able to get the information of what their causes of death were and be able to update our analysis. So before opening the floor to any questions or comments, I just want to acknowledge Dr. Klein and all the other PIs, as well as the participants in the cohort and all the study nurses and site coordinators who've taken the time to recruit patients and help them fill out questionnaires, and as well as the funding agencies. Thank you.
Thanks, Carmen. It's great. Good job. And any questions? It's getting towards the coffee break, so I think people are getting a little stuff.
I have one quick question. Did you look at alcohol in your population?
No, not at this point. But I'll hopefully in the next coming weeks when I look at it, I might add some more variables, and hopefully we'll get more causes of death to be able to power up our analysis a little bit further.
Just a quick question about you looked at HCV RNA as a time-dependent covariate.
Yes.
Did a lot of patients go negative, positive, or positive, negative?
No, there weren't a lot of switch arounds, but there were some, but not a lot when I looked at it.
And did you actually look at whether or not if that occurred, if that was like using that as a covariate, so changing from positive to negative over time?
No, I did not.
Okay. Probably not enough patients, but interesting. Thanks.
I will look into it. Thank you.
So,